Very good evening and a warm welcome to all the dignitaries present here. I am Momita from CareNet. Serving as the allocated session assistant to ensure a seamless experience. CareNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clinic serves as the digital partner for this event hosted by the Society of Onco-Anesthesia and Perioperative Care. And the focus of today's session is the artificial intelligence applications in head neck cancer. So let's begin to the session, for which I would like to invite Dr. Sohan Solanki sir to take over. Over to you, sir.
Thank you, Mamita. And I welcome you all for this webinar on the AI applications for the head neck cancers. And we all know that the AI is going to increase and going in a big way all over world. And we, in our domain, actually, in domain of the anesthesia and the intensive care, the maximum uses of AI applications, be it in the perioperative management, be in the patient for the preoperative assessment, in the intra-op management, for the hemodynamic management, for the intensive care management. So the AI is going to like take over all our space in the OT and the ICU and even the pain management. So I think we should be well aware and well versed with the whatever AI is coming up, and we should also understand how the AI works actually. What is the AI? What is deep learning? What is the machine learning? And what different parameters they use? And so we should be having some understanding of the AI, so that we can, when we use it, we know something like how it happens and how it works. So we can better understand their mechanism, and we can apply their things. But even if we don't understand much, but we have to have some idea, and we are going to increase them. We are going to get it anyway. You like or you don't like it, but AI is going to be there forever with us. So I think for the today's talk, like we will be more on the head neck cancers. We can assess the patients for the by the AI and how we will manage the patients. So for that we have Dr. Jagdish Sharma from Mahimaba Cancer Hospital, Chandigarh, and he's associate professor in Chandigarh, and he's like he will take us to the different domains of the AI in head neck cancer. So Jagdeep, please, you can start your presentation. And yeah.
Yes, sir. Thank you, sir. Can I share my slides, sir?
Yeah.
Good evening, everyone. So, the topic of my presentation is artificial intelligence applications in head and neck cancer patients. So, the first thing, can we heal the world? So, we will get back to this question after the end of this presentation. Coming on to the main theme today, that is artificial intelligence. So, artificial intelligence is based on reinforced learning, and it revolves around algorithms that allow machines to reason and perform functions like problem solving, object and word recognition, and also helping in decision making. In its most basic form, we can say the computers are programmed to mimic human behavior, and that's done by using examples of extensive past data of similar behavior. In 1950, Alan Turing first described the concept of using computers to simulate intelligent behavior and critical thinking. and that was later on got to know about that known as Turing test. So coming on to this landmark years in artificial intelligence, so it all started in 1950, and then in 1955 John McCarthy coined the term artificial intelligence. By 1975, computers became faster with increased affordability, and artificial intelligence was integrated to the medical field. And the first prototype for that was CASNet model for digital consultation of glaucoma. In 1980, first national conference was held by the American Association of Artificial Intelligence at Stanford University. By 2000, there was complete establishment of artificial intelligence, like development of Deep Blue. We all know that supercomputer that was developed in around 1996 and defeated Gary Kasparov, and followed by that integration of AI powered algorithms into the Google search engine that made it all the more relevant. And following that, there has been giant strides in our branch of anesthesia and critical care, with development of Kepler intubating system, Max Sleepy, Sidasys, and lot more things. Types of artificial intelligence: reactive AI. This is the basic form which works on preset data and can only react to already existing situations, as I already told about Deep Blue. Proactive AI, it comprises of machine learning models that derive knowledge from past learned information and that can be improvised. Theory of mind AI, it is more advanced in the form of works on emotional intelligence. It has decision making ability quite similar to the extent of human mind. Examples of that: robots, Kismet and Sophia. And the most advanced form, that is the self-awareness AI, which as of now it doesn't exist. These machines will have human level consciousness and understanding, monitoring, and awareness, and they will keep on adapting itself according to the changes in the perception of the various data. So, artificial intelligence, machine learning is a subset of artificial intelligence, and the term was coined by Arthur Samuel in 1959. Deep learning is a subset of machine learning. It's a more advanced and more complex form of machine learning. So, artificial intelligence using these applications in the form of machine learning, deep learning, and neural network algorithms have created significant breakthroughs in computer vision, intelligent robotics, natural language processing, semantic recognition, and image processing. So this is a very wonderful article published in Airway Journal in 2023 by Muthapalli Santhinathan and Pankaj Kundraji. That is predictive machine learning algorithms in anticipating problems with airway management. So they have explained different methods how the machine learning can be used in assessment of difficult airway. So that it being a subset of artificial intelligence, there are different types of machine learning. One is supervised learning, which is most commonly applied to our medical field. It is task driven, and there is a pre-specified output to the input data. Unsupervised learning or semi-supervised learning, in this that the output is not predetermined, and the advanced form is your reinforcement learning, and it is an algorithm in which that your algorithm is asked to attempt certain tasks, and it will learn from its subsequent mistakes by its own. So this is the simplified stepwise approach to machine learning algorithm for difficult airway. So what is happening here is that, first of all, the data set is prepared. The data set is prepared along the lines of your demographic data, your anthropometric data, your clinical evaluation, and then this algorithm is trained on this training data set. So this is the training data set which is put up in a training AI algorithm, and then some component of this data, around about usual ratio, that is around about 80% is your training data and 20% is your test algorithm data. And then your algorithm is tested for accuracy, sensitivity and specificity, and receiver operating curves, area under the curve is checked. And then this is depending upon your this accuracy and sensitivity, it is put up for the testing of the next subset of data. So the crux of the AI is that we use training data to train special algorithms to make a new prediction on a new instance of a process data. Okay, so what is the theme of perioperative intelligence? The core elements include your patients, healthcare providers, healthcare system, a huge amount of data sets, and then the data scientists, and then it is put up in the medical technology, and with the help of your artificial intelligence, that is given back to the patients. So it helps in identification of the patients at risk, and its early detection of complications, and timely and effective treatment by identification of risk and detection of complications. So there is another wonderful article, very exquisitely crafted by our own very own Sohan sir. It's an editorial, artificial intelligence in airway management and anesthesia, and it covers almost all aspects of practical implications of this artificial intelligence in different aspects of our branch. So now we will take this case scenario and we will try to apply the artificial intelligence to, in all different aspects which can be, which you will see in further slides. So this is a 44-year-old male, case of carcinoma of the left buccal mucosa, posted for wide local excision with left marginal mandibulectomy, neck dissection and flap reconstruction. So depending upon this case, what can be the, we will be discussing under the further discussion will be on this subheads. So the applications are like role in anesthesia, which will be going along your pre-operative assessment and risk stratification of the patient, intraoperatively, and before also prediction of the difficult airway and intubation, depth control of anesthesia during the maintenance and anesthesia controller, what can be the possible implications, and prediction of events such as hypotension and hypoxia. Post-operatively, we will be talking about the pain management and where are we in artificial intelligence right now, what can be the potential for future research, and what can be the challenges or limitations of AI. So first of all, in pre-anesthesia assessment and difficult airway, so this is a natural language processing algorithm of AI subcomponent, helps us to understand and do pre-anesthetic checkups in local language with the use of translation, as we commonly use, whenever there is language barrier. So this application helps us in translation of the documents and helps in doing the pre-anesthetic checkups in a more easy way. Google search, we commonly see there's a lot of comorbid patients who comes with prescription to our PSC clinics, and there will be around about 10 medicines, and out of which we won't be knowing some of the trade names of the drugs, and we would try to get what is the actual salt in them, what are the combination of salt. So Google search engine also helps in the immediate identification of the drugs with expertise of processing the past patient data. This helps us in risk stratification, and which this risk stratification helps in aiding physician in anticipating challenges and also customize the anesthesia plan as per the specific needs of the patient. So prediction of difficult airway, is an essential component as it has the potential to cause life-threatening complications, and various studies have who have checked the usage of AI in assessment of difficult airway has this as the basic concept in the data set. Like they will be doing a clinical evaluation, assessing of the difficult airway on the grading, your Mallampati grading, your head neck movements, your Lemon score, combination scores, and then the anthropometric measures, the distances, thyromental distance, hyomental distance, what is the interincisor distance, and then there will be a trained anesthetist who is going to do a laryngoscopy, and with the help of CL grading he is going to assign whether that intubation was easy or difficult. And then this training data is fed to the AI algorithm for further data analysis. So principal scores that have been used in these studies, which are going to discuss in later slides, they include the Lemon score, your Mallampati classification, and Al-Ganzori score. So this is the basic approach to airway management using AI and machine learning algorithms. So we can see that there is the huge amount of this data set, that data in the form of your demographic data, including your age, gender, estimated height, weight, BMI. Second data, that is your clinical evaluation on the basis of interincisor distance, thyromental distance, Mallampati score, upper lip bite test, extension, receding mandible, and neck movement. And third data in the form of your hemodynamic or your physiological parameters like blood pressure, heart rate, vitals, respiratory rate, saturation. And data 4 in the form of your imaging, what we get from imaging. So x-rays, MRI, CT scan. So this is all kind of data which have been utilized for this data acts as an input data. So that input data is put into machine learning algorithm, and that machine learning algorithm, after going through this various steps of learning, is going to give you an output in the form of decision whether it is an easy mask ventilation, easy intubation, difficult intubation, or easy intubation. So the basic concept stays the same in all the studies. So now coming on to this studies using the facial analysis technique. So these studies uses facial feature data from the patient database and fits it according to the algorithm. And rest of the data, like clinical evaluation, they used Mallampati grading, upper lip bite test, head neck movements, thyromental distance, or Wilson or Lemon score. And then the intubation was done, assessed with Cormack Lihan grading. And they found these multiple studies have found that these algorithm can easily be used during the pre-operative assessment and can enrich our capabilities for providing fast and safe results. So this is the study which was done by Hayasaka et al. That is, they used deep learning CNN neural network using the face images and for the creation of an artificial model for assessment of the intubation difficulty. This article was published in Journal of Internal Medicine in 2021. So what they did was they used a deep learning method of machine learning, and they examined around 1043 patients. 202 patients were included in met the inclusion criteria and was and they underwent, and this these 202 patients then underwent the further assessment in the that included your intubation difficulty. I already told that the CL grade was used. Grade 1 and grade 2 CL grades were the easy intubation, and grade 3 and 4 were the difficult intubation. Demographic data was used in the form of Mallampati grade and your head neck movement, upper lip bite test, and thyromental distance. So add on to this, they used facial images in 16 different positions. So this is on the left side, we can see that is your Cormac-Lehane grade, which was used for assessing whether it is a difficult or easy intubation. And then these 16 images were taken in different positions like supine, front closed, mouth base position, or supine side closed mouth base position. And then what did they find out? That AI models area under curve to classify the degree of intubation obtained from the patient facial images that varied from 0.387 to 0.864, and the maximum area under the curve was 0.864, which was obtained from which position? That was supine side closed mouth base position. It had an accuracy of 80.5%, sensitivity of 81.8%, and specificity of 83.3%. So we can see the results of other clinical evaluation parameters like Mallampati grade. We can see the sensitivity and specificity of those tests like interincisor gap. It had a sensitivity of 44.4% and specificity of 75%. And when these clinical evaluation parameters were compared with the best AI model, we can see that best AI model, which supine side closed mouth, had the sensitivity of around about 81.8% and specificity of 83.3%, and the area under the curve was 0.864. This is another study which was done by Wang et al. They used the semi-supervised deep learning model for this difficult airway assessment, and they assessed around about 1000 patients scheduled for surgeries under general anesthesia. As usual, the basic concepts stay the same. The demographic parameters, your clinical evaluation parameters in the form of thyromental distance, this is they use it as a then, but the difference is they used 9 images from 9 different viewpoints during the routine preoperative anesthesia procedure like this. So they take this 9 images in 9 different position, and this whole data was put incorporated into the artificial intelligence algorithm, and then they got the results. And what did they find out? That the AI algorithm provided the results on the basis having the accuracy of almost 90%, sensitivity to find out true positives in the 89.58%, and specificity of 90.13%. The area under curve was under the receiver operating curve was 0.94. So they concluded that a semi-supervised deep learning model can be used as an effective tool for identification of difficult mask ventilation and intubation. Sorry, it got hanged. Uh, are my slides visible?
Yeah, visible. Please go on.
Okay, okay, sir. After this, now coming on to the next part, that is difficult mask ventilation. So Baipai et al. In 2023 studied machine learning three-dimensional facial scan for the prediction of difficult mask ventilation. So they found that this 3D geometric morphometric in applied to an AI algorithm could be a rapid, efficient, and non-invasive tool for prediction of difficult mask ventilation. Some have also tried about that speech feature analysis, that is on the principle that acoustic parameters can reflect the anatomy of the upper airway, and the changes in this airway can bring about change in the pronunciation, making speech another significant comprehensive predictor of difficult airways. Now, coming on to this role of AI in video assisted laryngoscope or fiberscopes. So, right now, there is no active study being conducted for utilizing artificial intelligence in fiberscopes. But in video laryngoscope, the one shortcoming is with the 2D image deprives of depth perception. So this Song Jae Cho has published in 2023. He has developed an artificial model for video laryngoscopes, and in that he has tried to segment the structures in the oral cavity with identification by the video laryngoscope. And once it identifies, it focus on the specific features that is being segmented accordingly in the form of tongue, epiglottis, vocal cords, and the further corniculate cartilage, and thus helping in emergent intubations. Now, AI using various imaging methods, that is in the form of X-rays, CT scans, and MRI. Lakhani et al. In 2017 used a deep CNN to demonstrate that X-ray can detect the positioning of the endotracheal tube or tracheostomy tube. So they classified X-rays into 12 categories depending on the distance of the endotracheal tip and carina. And they found that area under the curve in identification of this right position or mal position of the endotracheal tube or tracheostomy tube is 0.99 for the best performing network and 0.81 for the most difficult dataset. Similarly, the CT scans are often used to reconstruct 3D images of airway anatomy, and that had been used in specifically in patients of obstructive sleep apnea. That from CT scan they could calculate the distance from the hard palate to the hyoid bone, and thus coming to know about the length of the airway tube, and thus helping in calculate the AHI index in these patients. So these head and neck cancer patients usually undergo, we know that, nasal intubation, and CT scan. This Grimes et al. Had done a study, and he found that nasal diameter of less than 6.3 mm can indicate nasal intubation difficulty. So that this AI algorithm fed data had the positive predictive value of around about 71.4% and a normal predictive value of 90.7%. MRI AI can be used to assist in identification and assessment of difficult tracheal intubations using MRI. There is one study done by Munster et al. And he reported in 142 patients correlation between the difficult laryngoscopy and anatomical position of the vocal cords concerning with the cervical vertebrae as assessed by the MRI. Unfortunately, beyond this study, there is very little research or evidence available to support the effectiveness of MRI in assessing difficult airways. Now, coming on to the robotics in airway management. Robotically assisted airway management is feasible using multi-purpose surgical robotic system, and Tighe et al. Used this Da Vinci surgical system type S for oral and nasal fiber optic intubation involving an airway mannequin. So we can see this in the airway. There's this Da Vinci surgical type system, and the bronchoscope is held, and they are performing the intubation in the airway mannequin. Another application in robotic system is Kepler intubation system. And this Kepler intubation system, it consists of a remote control center. We can see joystick, intubation cockpit, which is linked to a standard video laryngoscope via a robotic arm. So we can see the Kepler this is in the A, we can see the Kepler intubation system that is in the position 0, starting the intubation process. The video laryngoscope is attached there. And in image B, we can see the system view of the Kepler system, and the robotic arm is shown mounted on the operating table, and the joystick is shown on the far bottom left. The Pentax video laryngoscope is shown mounted on the robotic arm, and the endotracheal tube is shown mounted to the blade of the video laryngoscope. There is another publication in anesthesia in year 2020. There is this automated tracheal intubation in an airway mannequin using a robotic endoscope, a proof of concept study. So this is a robotic endoscope automated via laryngeal imaging for tracheal intubation. That is reality. It was developed to enable automated tracheal intubation. So we can see in this image that the operator is holding a laryngoscope on the left hand, which they have used to open the airway, and on the right hand with the joystick they are using a endoscope. So the end point of this study was only to measure whether that endoscope can reach to the tracheal ring and in what time. Intubation was not taken into consideration, and it has two modes. One is your automatic mode and your manual mode. And the uh, on the right side, this is the image which is showing once there is a laryngeal imaging is there, endoscope automatically goes through and reaches the tracheal rings. So coming on to the next aspect of this our anesthesia components, that is your monitoring and closed loop anesthesia delivery. This is now the next step in the maintenance of anesthesia, how the AI can be incorporated. AI can be used to improve the depth of anesthesia monitoring. This article published in 2006 in anesthesiology, that's a titration of propofol for anesthetic induction and maintenance guided by the bispectral index. So they compared closed loop versus manual control. It was a prospective multi-center study, and they found that the results were that automatic control of consciousness using the BIS is clinically feasible and outperforms manual control. So majority of studies have used BIS and EEG to assess the anesthetic depth, which is not surprising given the research efforts to reducing the risk of intraoperative awareness. So now what is the literature evidence to this? What they have, how the AI has been incorporated? Mir Sadeghi et al. In 2016, they compared the accuracy of their machine learning method, and the data for their machine learning was the signals, EEG signals, and they compared the identification of anesthetized patient versus the awake against common use of BIS index. And the results were that their machine learning model, the accuracy was 88.4%, and BIS index had an accuracy in that was 84.2%. Zhang et al. Used mid-latency auditory evoked potentials from patients and used neural networks to assess the accuracy. So in that study, they found that the machine learning model based on mid-latency auditory evoked potentials determined the patients on awake with 96.8% accuracy, adequately anesthetized 86% accuracy, and on emerging from general anesthesia with 86.6% accuracy. So this is the closed loop anesthesia delivery system, and we can see the closed loop in which there is a patient which is going to be sedated, hypnotized, or relaxed, and these patients are monitored with BIS, EEG, or mid latency auditory evoked potentials, and monitored phonomyography for muscle relaxant. And then this data is used by the interface system, and then the action is done by the target controlled infusion pumps, like administration, whether that needs more propofol or remifentanil or a relaxant. Coming on to the next aspect in this head and neck cancers, these patients usually intraoperatively uh, being undergoing duration a long duration of surgery, they all have a chance of getting hyper fall in BP, and also there are chances of hypoxemia. So intraoperative hypotension, that's defined as an MAP of less than 65 mm of mercury, is associated with an increased incidence of postoperative MI and acute kidney injury. We all know that. So post-induction hypotension is a significant cause of distress for the anesthesiologist. Kang et al. In 2020 used this machine learning algorithm to predict this post-induction hypotension, and the parameters which had the highest which impacted the accuracy of machine learning were the patient's lowest systolic blood pressure, lowest mean blood pressure, and the mean systolic blood pressure before tracheal intubation. And then this data went through this random forest algorithm, and the prediction was area under curve of 0.84. And whenever the area under curve is more than 0.75, the test has good accuracy and a reliable one. Vanderven et al. In 2021 described the hypotension prediction index, and with HPI, we all know it's a unitless number that ranges from 1 to 100. And as the number increases, the more is the chances of hypotension in the near future. And this was validated by Davies et al. And he did HPI, validated the HPI performance in 255 patients who were undergoing the major surgery, and the predictions in the close to the actual onset of hypotension within the first 5, 10, or 15 minutes before hypotension had an area under the curve of 0.93, 0.9, and 0.88 respectively. Hypoxemia, it can cause serious harm to the patients when it occurs under GE or surgery. And Scott et al. And Zhang et al. Have tried to incorporate this AI into this detection. So Scott et al. In 2018 developed and tested a machine learning based algorithm, and he found that anesthesiologist can predict if an anesthesiologist can predict 15% of hypoxic events. If they incorporate this AI algorithm, their predictive ability increased to 30%. Zhang et al. In 2019 used this artificial neural network model in predicting hypoxemia during propofol-based sedation for gastrointestinal endoscopic procedures, and they found that these three variables were important in predicting hypoxemia. That is your BMI, habitual patients who are habitually snoring, and the neck circumference. Now coming on to this another aspect, that is AI in post-operative pain management. So it has been used in wireless intelligent PCA patient-controlled analgesia, which incorporate the following remote monitoring, intelligent analysis and alarm system, assessment of PCA equipment, which can and automatically records the data, reserving key information, and the most important is your wireless environment. So whenever there is increase, whenever the patient feels pain, then there is a signal sent which through which the patient is being delivered analgesia. So this is just to show the components. There is a central server, there is input and output terminals, and then there is your Wi-Fi or analgesia pump, wireless. That is, it's not using any wires, and it's wireless analgesia pump which will deliver the drug. Role in surgery, we all know that various hyperspectral imaging can distinguish between normal and cancerous tissue. Analyzing images, voice and molecular expression helps improve the diagnostic accuracy. So it also helps in creating predictive models for prognosis, survival, and probability of metastasis, which in turn impacts the treatment outcomes. It also helps in AI incorporated into this algorithm, help plan the type of treatment which is required, whether it is radiation or whether the patient should undergo surgery. Intraoperatively, we can plan what are the tumor margins, whether the tumor peripheral site is free of the tumor margins or not, and it has also helped in predicting the chances of free flap failure and reducing the surgical site infections. So, robots in anesthesiology, the main goal is to assist the clinician in delivering services with precision, accuracy, and safety. So, the most common types of robots we have include in our field include pharmacological. The most traditional ones we all know about the target controlled infusion systems, which are pharmacokinetic or pharmacodynamic based systems, and they can induce and maintain hypnosis, analgesia, and neuromuscular blockade. Your mechanical robots like Kepler intubation system, decision support system, and the Da Vinci surgical system. So coming on to this important invention, which was done in the form of Max Sleepy. Max Sleepy is a sort of humanoid anesthesiologist, and who thinks like an anesthesiologist. It analyzing medical information, continuously monitoring and adapting its behavior depending upon the received inputs from the your monitors. So it was McGill University of Health Center performed its world's first uh, automated administration of anesthetic in May 2008. The patient underwent partial nephrectomy. Duration of surgery was around 3 hours and 30 minutes. So this is having that closed loop anesthesia, closed loop administration of anesthesia, in which the hypnosis was assessed via the EEG, electroencephalogram, pain via a new pain score called an Algo score, and muscle relaxation via the phonomyography. And finally, the Max Sleepy met Da Vinci on 19th October 2010, when the whole robotic surgery was done at Montreal General Hospital when the patient underwent prostatectomy. So uh, this is the interface showing your bispectral index, your analgeo score, your neuromuscular blockade, which is assessing the status, and then the drugs being given through the this in the form of bolus, or whether it is maintenance or it is in the form of induction. Another system in the form of Sedasis. The Sedasis system, it is a computer-assisted personalized sedation system that administers propofol for minimal to moderate sedation. So it was meant to be used by the non-anesthetic physicians who were doing these endoscopic procedures, and US FDA approval was given for this device, on which was launched on May 2013. Parameters monitored were arterial oxygen saturation, heart rate, respiration rate, blood pressure, and patient responsiveness. And that system was divided into four subsystems. These are the bedside monitoring system, the procedure room unit, reusable monitors and connectors, and the one of the single use patient use devices. So where are we right now in artificial intelligence? If we go make an this XY graph of expectations versus time, we think we believe that we are at the peak of inflated expectations. We have predictive algorithms which warn ahead of clinical situations, but these tools are not prescriptive, but just only predictive, which is helping us what can happen. Why? why I why we are at the peak of inflated expectations? I will give an example for the same. This is the article published in Anesthesia Analgesia in February 2017. Failure of Sedasis, Destiny or Poor Design. So there are multiple reasons. I just told how Sedasis is functioning, and now there is article which showing that there is a failure of Sedasis. that multiple reasons have been cited in this article regarding various causes of failure of sedasis. That is, this machine in this closed loop delivery system was only programmed to decrease the depth of sedation. It was not programmed to increase the depth. If there is any, if the patient is light, there was no programming to increase the depth of sedation. So that was one aspect. Secondly, US FDA approval was there only for mild to moderate sedation, but once there was an audit, they found that there most of the patients were in more deepened plane of anesthesia rather than in mild to moderate sedation. So that is why this sedasis was taken off. So now coming on to the first question I asked in my first slide, that can we heal the world? So there is a significant difference between rural and urban population in India. By data, we can say around 68.8% of India's population reside in rural areas. And we saw that telemedicine powered AI, which allows patients to consult doctors remotely, we saw a massive surge in COVID-19 pandemic. For India's rural areas where access to specialists is limited, this can provide real-time diagnostics and virtual consultations, making healthcare more accessible and thus helping in widespread of equitable distribution of your healthcare. Now coming on to the challenges of artificial or limitations we can say with artificial intelligence, uh, there are black box results. The algorithm can provide a predicted outcome for a clinician or researcher, but some of the results it cannot reveal any further information about why did it come to a particular result and why that prediction was made. So there is a need to make algorithms which are more transparent and thus strengthening the human trust in understanding these predictions. AI is excellent at demonstrating correlation or identification or prediction in patterns, but yet it's not able to determine the causality, and which is at least the extent needed for clinical implementation. I just gave an example of closed loop system versus open loop system. How sedasis with not a properly programmed closed loop system had to be withdrawn from the market. Susceptibility to data bias is another aspect. Whether the manufacturer, what kind of data is being fed to the AI, whether that algorithm is that data is biased, how the AI is going can be implemented, whether it can be implemented to the cross populations depending upon that data. It's all susceptible to bias. So any machine, there are chances of software failure, connectivity issues, wrong input of patient data, credentials, and regarding surgical data. And if something goes wrong, who will be responsible? So right now, till now, we all know that your AI is just augmenting or helping the decision making, but it's so right now, if something goes wrong, its whole responsibility lies with the clinician. Should patients consent to the use of AI? Answer to that, like if we are administering anesthesia, the we take consent for that, and over a period of time, till that loop is not fully closed, we can take care of that whether the consent is required or not. But I think it's going to be a big issue over a period of time. So, ethical challenges that must be identified and mitigated in a way that preserves patient safety, privacy, and autonomy. And we must examine how our branch will address machine learning. What impact do we want to have in our field of anesthesia and prevent potential harm to patients and clinicians? So I will say that the future is not man versus machine, but the future is man with machine versus a problem. Thank you so much.
Okay, so thank you, Jagdeep. You finished your lecture, right?
Yes, sir. Yes, sir.
Okay. So I invite the questions for this webinar, and thank you for a detailed and very good and comprehensive presentation about the AI and the role of the AI applications in the head neck cancer, especially the pre-op assessment and the other part. So you can uh, stop sharing your slides. So if there any questions from anybody, there's one question from Dr. Dipali, and she's saying that the practically effective, cost-effective AI tools that can be used at the moment in the difficult intubation head neck cancers. So, do you want to take this question?
Sir, I didn't get it, sir. Sir, can you please repeat, sir?
Practically effective, cost-effective AI tool that can be used at the moment in the difficult intubation in head neck cancers. You can also see this question in the in this chat box.
Yes, sir. Practically cost-effective AI tools, as I through my presentation, uh, it's more clinically we- clinical evaluation and anthropometric data, which we are using. I will take it in this way that whatever data we are having, like whenever the patient is going through this like like our hospital, we are having electronic health records. So we this when the patient is coming for pre-necessity checkup, we examine the patient. This patient goes through the surgery. Okay, so we have that data filled by the surgeon, by the anesthetist, if anything eventful which has happened through all this procedure. So once this patient is going to come for another surgery, there is we will get it will help us in planning of our anesthesia, whether this patient had any allergy, any history of your difficult intubation, difficult airway. So that this data right now, which we have in the form of electronic health records, that can be utilized in the form of various clinical apps. So this, these apps, fast track, or in various hospitals, they're using these apps where they just put in the name of the patient and number, and whenever this patient is going to come for a surgery, like any exploratory laparotomy, any emergency surgery, and immediately we put in the data, we get the details. What were the comorbidities? What are the any specific anesthesia related issues which happened during the previous surgery? So I think that is a very practical aspect. Rest of the things, data is the main key. We have to build our own data. We should not depend upon importing data from outside, which I don't think can be practically applied to our subset of patients in all the ways, and that might lead to creation of data bias. So we have to create data sets, we have to assimilate data, and we have to use that data in a whatever practical way which is possible and feasible in a particular hospital to give the best benefit to the patient.
Answer questions are in the chat box, sir. You can.
Yeah. Practically cost effective tools. We are done. Excellent class. Just like we have, yeah. My Gaurmitra ma'am has just mentioned that we are also using Hemosphere for hemodynamics, and we are also we just did a workshop, and that was having simulation. So that's one of the practical aspects for giving like far off students studying in far off areas. So those students might not be having an access to the infrastructure which is available in the main urban center. So we can create this AI can help in development of simulation and simulation based training, so that once that simulation based training is there, that is going to help in spreading the information and whatever be the infrastructure in the central areas to the.
So Jagdeep, like I can like just mention like just like this hemisphere which can predict like a predictive model of the like HPI, right? The HPI predict the hypertension the 15 minutes prior to the what is happening hypertension in reality. So like that way, asking is any other model area. So like you are mentioning in one of your slide the reality, the reality software which like we take the pictures of the different views of the laryngeal inlet, and that will tell you how difficult or how difficult is going to be your intubation, or what will be your CL grading. So it will take like thousands or lakhs of data, and that will create a good image like in which patient you can go to have a different intubation. So currently it is not really in very much practice, but yeah, we are going to have these kind of models, which is so in AI, the predictive model always best, then the proactive, and then the reactive. So reactive, we just act when there is something happens. Proactive, we always prepared for something with what's happening, and the predictive model is always best in AI. So and then Dr. Shagun Bhatia asked that could you tell us about the level at which the nasal diameter was measured to predict the difficult intubation for this PPV of 90%? Was it photograph or was it MRI image?
Uh, this was uh,
So yeah, I think it must be the MRI image or something like that.
MRI, sir, it was it's CT scan based. So this was a CT scan based image, and the level they have not mentioned. They have just mentioned the diameter of the nasal in that Grims et al. They did publish this using CT scan for that, and that showed that this at the diameter, if it's less than 6.3 mm, it was not. It's not. They have not mentioned specifically where the level it is mentioned, but if it's less than 6.3 millimeter, then the chances of nasotracheal intubation is difficult.
And the thing is that one more question: how you collect the data at your center? So I don't know. Actually, the data the at present we are not entering into the app or any software, but it's the data which is coming in from the hospital EMR or your like automated monitoring system, automated data collection and monitoring system that will lead to the future AI development. So as at present we are not using any app or software to collect the data and then lead to into the our AI model, because whatever the AI model we are using in the hospitals are not from our data. So it is from the different data. Most data are from the Western centers, not from India. So in future we are going to have a like Indian data also in the Indian patients. We will have like the software based on the Indian patient data. So right now we are not doing all these things. Gauri Mitra madam, I have asked one more question. Are we making capture point point on red caps? So red caps is currently we are using for the studies and all data we are mentioning, but patient data, yeah. So like all the studies, whatever we are doing in on the in at least in TMS, we have to enter on in the red cap to the analyze all these things, but they are not yet in the form of the whatever the AI outcomes or whatever we may be having in future. So we don't know really. ज्योत्सना मैम इधर ये और कौन है so yeah, anybody else? Jyotsna madam, we want to ask, you want to say something?
It was an excellent presentation by Dr. Jagdeep, very good presentation. And we know it is AI is coming by big way everywhere in every sphere, every aspect. But actually in reality we are using to some extent like TCI pump and Hemosphere, that HPI monitor, all those things. But I feel that man behind the machine is most important thing, and AI is very good as long as the physician will use it. They know it better how to use it and what is the drawback, what is the problem, how to use it. So that is the most important thing. And but it is going to come the way it is going on. It is going to come in our practice slowly and gradually, more and more. So we should be aware of everything, how to use it, what is the pitfall, how to, what is the complication can happen. Everything we should be aware of, and we should welcome the things, new things to come.
Yeah,
But it
so
was a very good presentation by Dr. Jagdeep.
yeah, so actually there are like many people, they ask me when I have given this like talk on AI on intrusive conferences. They always ask me if this will AI replace anesthetist, so that AI cannot replace anesthetist, but the anesthetists who are using AI will definitely replace anesthetists who are not using AI.
Not using.
Yes, that is the thing. It has to, it is coming, it is going to come. So we should know more and details about this, how to use it and what, that is the main thing actually. So we should, we need more and such talk, more such presentation, all those
Yeah,
things,
so
so that we
and
should train
and it was
ourselves.
but a really good presentation, Jagdeep, and
Very
Thank
good
you.
presentation.
Thank you, sir.
so if we, I think we don't have more questions, and it already we've crossed the time. So thank you very much all for joining today for this webinar, and we will meet you after 2 weeks. Thank you, Jagdeep, and Mamita, it's over to you.
Thank you, sir. Thank you. Thank
Thank
you.
you,
sir.
thank you,
Thank you.
thank you.
Thank you so much.
Thank you so much, sir, and thank you so much, everyone, for giving us this opportunity to host this session. So now, with all due permission, I'm closing the session here for today. Thank you so much, sir.
Thank you.